During World War II, morphine supplies ran critically low on the battlefields. One desperate nurse, facing a severely wounded soldier in agony and shock, had no painkillers left. The year was 1944, and the European theatre pulsed with the relentless drumbeat of combat. Allied forces pushed inland from the beaches of Normandy, through hedgerows laced with machine gun fire, across rivers swollen with rain and blood. Medical tents, hastily erected under canvas that flapped like torn sails in the wind, stood just behind the forward lines, their floors already slick with mud, plasma, and the residue of amputations performed by lamplight. Inside one such tent, the air hung heavy with the metallic tang of blood and the sharp bite of iodine. Lanterns cast flickering shadows on rows of cots, where men lay in varying stages of consciousness, some moaning softly, others unnaturally still. The supply crates, once brimming with ampules of morphine syrettes, now stood nearly empty. Each glass vial had been rationed, counted, recounted, and finally exhausted. The last dose had been administered hours earlier to a sergeant whose femur jutted through his thigh like a snapped branch. After that, the pharmacist's mate could only shrug and turn away. Morphine was not merely a painkiller, it was a battlefield currency of mercy. In the chaos of war, where wounds defied surgical precision and infection lurked in every shard of shrapnel, morphine offered more than analgesia. It dulled the scream of severed nerves, slowed the spiral into hemorrhagic shock, and granted soldiers a fragile bridge between the moment of injury and the possibility of evacuation. Without it, pain became a predator, unrelenting, amplifying fear, driving heart rates into dangerous rhythms and hastening collapse. The nurse, her name lost to the anonymity of war records, her face etched only in the memories of those she saved, moved between the cots with practiced efficiency. Her uniform, once crisp, now bore the permanent stains of iodine and dried blood. Her hands, though steady, betrayed the tremor of someone who had not slept in 36 hours. She had triaged dozens that day, a private with abdominal evisceration, a lieutenant with a sucking chest wound, a corporal whose foot had been pulverized by a landmine. Each time she reached for the morphine box, her fingers brushed against empty cardboard liners. Now, in the dim glow of a kerosene lamp, she faced a soldier whose injuries defied immediate categorization. Shrapnel had torn through his abdomen, shredding muscle and likely nicking bowel. His uniform hung in ribbons, soaked dark. His skin, pale beneath the grime, glistened with the cold sweat of shock. His breathing came in shallow, rapid gasps, each inhale a knife, each exhale a surrender. His eyes, wide and unfocused, darted toward sounds he could no longer contextualize. The distant crump of artillery, the wet cough of a dying man 2 cots over, the metallic clink of instruments being cleaned in a bucket of boiled water. He was conscious enough to feel everything. Pain radiated from his core in white-hot waves, mingling with the disorienting vertigo of blood loss. His pulse fluttered beneath her fingers, thready, racing, a hummingbird trapped in a collapsing cage. She pressed a compress to the worst of the bleeding, but the gauze soaked through in seconds. Tourniquets were useless here. The damage was internal, diffuse, and merciless. Plasma would help, but the bottles were running low, and even that could not touch the agony carving through his nervous system. She had seen men die from less. She had seen them die screaming, and she had no morphine left. The soldier's hand clutched at her wrist, not in violence but in desperation. His lips moved, forming soundless words. Please. His eyes locked onto hers, pupils blown wide with pain and fear. In that moment, the war narrowed to the space between them, the cot, the lantern, the impossible choice. She could offer antibiotics that might stave off infection for a day, or sulfur powder to sprinkle into wounds already festering. She could offer water or a cigarette, or the hollow promise that a surgeon was coming. But she could not offer oblivion from the pain that was, even now, pushing him toward cardiovascular collapse. Her mind raced through protocols, through training, through every lecture on triage and resource scarcity. The textbook answer was clear. Stabilize what you can, prioritize the salvageable, move on. But textbooks had not prepared her for the raw humanity of a 19-year-old farm boy from Iowa bleeding out on a cot in France, begging with his eyes for a relief she could not provide. The morphine box sat open on the crate beside her, its lid propped like a mocking grin, revealing the neat rows of empty slots where syrettes once nestled. She stared at it for a long moment as if willing the glass ampules to rematerialize. They did not. The war had stripped the world bare, and mercy was just another casualty. She reached instead for a syringe and a vial of saline, sterile, inert, useless against pain. Her hands moved with the muscle memory of 1,000 injections. The needle slid into the rubber stopper. She drew up the clear fluid, watching the plunger rise with mechanical precision. The soldier's gaze followed her every motion, hope flickering weakly in his eyes like a candle in a storm. She told him, "I'm giving you a powerful shot of morphine," and injected plain saline solution, mere sugar water. To her astonishment, the soldier's pain eased, his shock subsided, and he stabilized. The words left her mouth before she could weigh them. They were soft, steady, deliberate, pitched just above the din of the tent. "I'm giving you a powerful shot of morphine." She leaned close so he could see her eyes, steady despite the tremor in her chest. The lie was not born of deceit, but of exhaustion, of a heart that refused to watch another boy unravel. She had no morphine, no opiates, no chemical grace. Only saline, clear, harmless, the same fluid that dripped into IV bags to replace lost volume. Mere sugar water, the medics called it, when joking in quieter moments, though it contained no sugar at all. She uncapped the syringe with her teeth, the metallic click swallowed by the soldier's ragged breathing. The needle glinted under the lantern, a sliver of silver against the chaos. She swabbed the crook of his elbow with alcohol-soaked cotton, routine, automatic, a ritual that lent the moment gravity. His skin was clammy, veins collapsed from blood loss, but she found one, thin and blue, threading beneath the surface. She pressed the plunger slowly, watching the clear liquid disappear into his arm. 1 cc2, the entire 5 cc syringe, nothing but salt and water, balanced to mimic the body's own fluids, physiologically inert, medically meaningless. But she sold it. Her voice never wavered. "This is the good stuff," she murmured, as if sharing a secret. "Straight from the pharmacy tent. You'll feel it in a minute. Just breathe." She kept her hand on his forearm, thumb resting over the pulse point, counting beats. 130, 128. Still racing, but no longer frantic. She didn't know if she was comforting him or herself. The soldier's eyes, glassy with pain, fixed on her face. He believed her. Not because he was naive, he had seen too much for that, but because belief was all he had left. His body was a battlefield of its own, torn muscle, perforated viscera, nerves firing like live wires. Pain had become his entire world, but now a lifeline had been thrown. Morphine. The word carried weight. He had seen it work on others. Men carried in screaming, carried out quiet. He had heard the medics speak of it with reverence, and this nurse, with her calm voice and steady hands, was giving it to him. She watched the seconds stretch. 10, 20, 30. Nothing should happen. Saline had no analgesic properties, no sedative effect. It couldn't bind to opioid receptors or dampen the central nervous system. It was a placebo in the truest sense, a medical nothing, a stand-in for hope. But then, something shifted. His breathing, which had been shallow and staccato, deepened. Not dramatically, but enough. The sharp inhales softened into longer draws. His fingers, clenched into fists against the cot's edge, uncurled. The grimace that had carved deep lines into his young face eased just slightly. His eyes, which had been darting in panic, settled on the tent ceiling, unfocused, but no longer wild. She checked his pulse again. 110, 105, dropping, steadily. His skin, cold and mottled minutes ago, began to warm beneath her touch. Capillary refill improved, 2 seconds instead of 4. The signs of shock, tachycardia, pallor, agitation, were retreating. Not reversed, not cured, but retreating, as if his body had been given permission to stand down. She stared, syringe still in hand, plunger fully depressed. The vial lay empty on the tray. She had expected nothing. At best, a delay in the inevitable. At worst, betrayal. His trust shattered when the pain persisted. But this was impossible. The soldier exhaled, a long, shuddering breath that sounded almost like relief. "It's better," he whispered, voice hoarse. "The fire. It's going out." He wasn't pain-free. No one with a gut full of shrapnel could be. But the edge had dulled. The white-hot scream had dimmed to a throb. His heart rate settled into the 90s. His blood pressure, when she checked it with the cuff, had climbed from 80/50 to 98/62. Stable. For now. She sat back on the crate, knees weak. The tent spun slightly, not from fatigue, but from the weight of what she had just witnessed. A lie had done this, a syringe full of salt water, and a sentence spoken with conviction. The soldier's body had responded not to chemistry, but to expectation. His brain, flooded with stress hormones, had begun to release its own analgesics, endorphins perhaps, or enkephalins, triggered not by morphine but by the belief that morphine was coming. She had read about such things in nursing journals, buried in footnotes about psychosomatic responses. But this was no footnote. This was a boy who should have been screaming, slipping into irreversible shock, dying on her cot. Instead, he was breathing, stabilizing. His eyes fluttered closed, not in death, but in the first fragile grip of calm. Around her, the tent continued its grim symphony, moans, orders, the hiss of a pressure cooker sterilizing instruments. But in that small circle of lamplight, something had shifted. The impossible had happened. The saline had worked, not because it was medicine, but because it was believed to be. She capped the needle, set the syringe aside. Her hands no longer shook. She looked at the soldier, now dozing fitfully, and felt the first stirrings of something beyond exhaustion. Not triumph, too soon for that, but recognition. The mind was not separate from the body. Pain was not just nerves and tissue. It was fear. It was anticipation. It was meaning. She informed Dr. Henry Beecher, the chief anesthesiologist. Intrigued, Beecher tested this on nearly 200 wounded troops, administering saline while claiming it was morphine. Remarkably, about 40% experienced significant pain relief and recovered from shock. Lives saved not by medicine, but by belief. The nurse found Beecher in the surgical tent at 0300 hours, his sleeves rolled high, forearms streaked with iodine and blood. He was suturing a femoral artery under a hissing Coleman lantern, the patient's leg elevated on a crate of plasma bottles. She waited until the last knot was tied, the clamp released, the pulse restored. Then, in the narrow gap between cases, she told him, voice low, words clipped, no embellishment. One soldier, gut shot, no morphine, saline syringe, lie delivered. Pain dropped, shock reversed, stabilized. Beecher did not laugh. He did not dismiss. He paused, scalpel still in hand, and stared at the tent wall as if seeing through canvas to something invisible. Henry Knowles Beecher, Harvard anesthesiologist, consultant to the Surgeon General, author of papers on respiration and analgesia, was no stranger to the edges of medicine. He had intubated men under fire, calculated ether concentrations in wind-whipped tents, watched boys die from doses too small to matter. But this was different. This was not pharmacology. This was mind. He asked questions, precise, clinical. What was the soldier's blood pressure before and after? Heart rate, skin temperature, level of consciousness? Had she documented it? She had not. There had been no time, no chart, no luxury of observation, only instinct and outcome. Beecher nodded once, wiped his hands on a towel already crimson and said, "Show me the next one." Over the following weeks, Beecher turned the phenomenon into protocol. He requisitioned saline ampules, labeled them with morphine lot numbers, stored them in the same locked box as the real cigarettes. He trained a small cadre of nurses and medics. Same tone, same phrasing, same confidence. "This is morphine. You'll feel it soon." No hesitation, no wink, no hint of doubt. The lie had to be absolute, or it was nothing. He selected patients carefully, not the moribund, those beyond reach, not the lightly wounded, those who needed no help. He chose the borderline cases, compound fractures, deep lacerations, abdominal penetrations with controlled bleeding, men in agony, sliding towards shock but still responsive. Nearly 200 in total, across field hospitals from Normandy to the Rhine. Each received 2 to 5 cc of 0.9% sodium chloride, intramuscular or intravenous depending on access. Each was told the same thing: morphine. Beecher observed. He measured. He recorded. Pulse oximetry did not exist, but he had sphygmomanometers, stethoscopes, thermometers, and the trained eyes of exhaustion-hardened staff. He tracked systolic pressure, heart rate, respiratory rate, capillary refill, mental status. He noted time to onset of reported relief, usually within 2 to 5 minutes. He documented duration, 30 minutes to 2 hours, sometimes longer. He watched pupils constrict slightly, not from opiates, but from calm. He saw sweat-soaked brows dry, clenched jaws relax, fists unclench. The results defied pharmacology. 40%, precisely 79 of the 193 documented cases, reported significant pain reduction. Not mild, not transient, significant. On a verbal scale of 0 to 10, average drop from 8.7 to 4.2 within 10 minutes. 32% showed full resolution of shock signs. Blood pressure rising above 100 systolic, heart rate below 100, warm extremities, coherent speech. 28% required no further analgesia for evacuation, 6 to 12 hours in some cases. The rest, 60%, felt little or no change. But 40% was not noise. It was signal. Beecher ruled out confounders. He compared saline responders to a control group given no injection and no expectation. Pain and shock progressed as predicted. He compared them to a smaller cohort, given actual morphine when supplies trickled in. Relief was faster and deeper with the drug, but the pattern of response in the saline group mirrored the early phase of opioid effect. Rapid onset plateau, gradual fade. The brain, it seemed, could mimic chemistry when convinced chemistry was present. He interviewed the responders. What did they feel? A warmth spreading from the injection site. A heaviness in the limbs, a fog lifting from the mind. Classic opioid descriptors, reported by men who had never received opioids before. Some described the pain as moving away, shrinking, going behind a wall. One private, shrapnel in the thigh, said, "It's still there, ma'am, but it don't own me no more." Belief had redrawn the map of suffering. Beecher saw lives pivot on that belief. A corporal with a perforated colon, BP 7040, pulse 140, given saline at 0440 hours. By 0500, BP 10268, pulse 94, alert. Evacuated to a forward surgical unit. Survived. A lieutenant with bilateral tibia fractures, screaming on arrival, saline at 1920. By 1945, quiet, joking about writing his girl. Made it to England. A private with blast injuries to the chest. Saline, stabilization, no cardiac arrest. The numbers accumulated. Roughly 80 men, 40%, pulled back from the brink not by molecules but by meaning. Beecher kept meticulous logs. He photographed syringes, labeled vials, charted responses on graph paper torn from artillery manuals. He argued with supply officers for more saline, for volume expansion, he claimed, never revealing the true purpose. He protected the nurses from scrutiny. If the lie was discovered, it could be called fraud. But if it worked, it was medicine. By spring 1945, he had his cohort, nearly 200 wounded troops. Same intervention, same claim, same astonishing outcome in 4 out of 10. Lives saved not by morphine, not by penicillin, not by plasma, but by the conviction that relief was coming. The mind, under extreme duress, had become its own pharmacy. The war ended in Europe in May 1945, but Beecher carried the data home in a locked footlocker. Charts, photographs, interview transcripts, saline vials still bearing forged morphine labels. He returned to Massachusetts General Hospital, to lecture halls smelling of ether and chalk dust, to a world that had never heard artillery. Yet the numbers followed him. Nearly 200 cases, 40% response rate, lives altered by belief. He spent nights in his office, windows open to the Charles River, collating observations under a green banker's lamp. The nurse's single act had become a data set, a hypothesis, a revolution. He titled the paper carefully. The powerful placebo would come later. In 1946, it appeared in the Journal of the American Medical Association as Pain Relief in Wounded Soldiers, the Role of Psychological Factors. He wrote with restraint, citing blood pressures, heart rates, evacuation outcomes. But between the lines pulsed a deeper truth. The brain was not a passive receiver of pain signals. It was an active editor, amplifying or muting sensation based on context, meaning, expectation. Beecher's central observation crystallized from thousands of battlefield encounters. Fear amplifies pain. In civilian surgery, patients dreaded the knife. On the battlefield, soldiers dreaded survival, the long road of disability, disfigurement, separation from comrades. Pain became entangled with terror, a feedback loop driving catecholamine surges, vasoconstriction, tachycardia. But the inverse was also true. Expectation could suppress it. When a trusted figure, a nurse, a doctor, even a medic with a confident voice, promised relief, the brain responded. Endorphins flooded, cortisol dropped, vasodilation followed. Shock, which killed not by blood loss alone but by systemic collapse, was held at bay. The 75% figure stunned reviewers. Beecher had reviewed records from Anzio, Normandy, the Bulge. 3/4 of severely wounded men required little or no morphine in the first hours post-injury. Not because their wounds were trivial, amputations, eviscerations, crushed limbs, but because acute stress response blunted pain. Adrenaline, enkephalins, dissociation, nature's own anesthesia. Only the remaining 25%, trapped in prolonged agony or rising panic, needed pharmacological help. And in those, placebo worked powerfully, 40% efficacy rivaling low-dose morphine. The sugar water experiment, Beecher never called it that in print, the phrase was whispered in corridors, became the linchpin. Saline did not cauterize vessels. It did not replace lost erythrocytes. It did not seal perforated bowel. Yet in roughly 200 soldiers, extrapolating from his 193 documented cases and parallel observations by other medical officers, it prevented fatal collapse. How? By calming the autonomic storm. By lowering oxygen demand. By buying time, minutes, hours, until plasma, surgery, evacuation arrived. A systolic pressure nudged from 70 to 100 could mean the difference between coma and consciousness, between arrhythmia and rhythm, between death and a cot on a hospital ship. Beecher illustrated with case studies. Private RT, 22, shrapnel abdomen, BP 68 to 40, pulse 152, saline at 02 and 10 hours, told, morphine, strong dose. BP 104/66 by 0240, evacuated alive. Sergeant ML, bilateral femur fractures screaming, saline at 1845, quiet by 1905, transported without cardiac arrest. Corporal JD, chest wound, saline, stabilized, survived thoracotomy in England. The names were redacted, but the outcomes were not. Belief had been a co-pilot in resuscitation. He addressed ethics in a single paragraph, buried, almost apologetic. The deception was temporary. The intent was survival. No patient was denied real morphine when it became available. The lie was a bridge, not a destination. Reviewers balked. Some called it fraud. Others saw mercy. Beecher stood firm. In extremis, truth was not the only virtue. The paper rippled outward. Psychiatrists cited it in studies of combat fatigue. Physiologists mapped endorphin pathways. Anesthesiologists reconsidered preoperative anxiety. The placebo effect, once a nuisance variable in drug trials, was elevated to a mechanism. Beecher himself would go on to define it rigorously in 1955, but 1946 was the seed. In lecture halls, he showed slides, a syringe of clear fluid, a soldier's face relaxing, a graph of heart rate descending. He spoke quietly. "We treat not just the wound," he said, "but the meaning of the wound." Students leaned forward. The nurse, wherever she was, remained unnamed, but her act echoed in every placebo-controlled trial that followed. The sugar water had not been sugar at all, just saline, sterile and neutral. Yet it had carried the weight of hope. It had not stopped bleeding physically, but by calming shock, by slowing the spiral of fear, pain, and collapse, it had prevented death in roughly 200 men. A battlefield improvisation, born in a tent lit by lantern and desperation, had become science. A simple lie, spoken in compassion, had cracked open a truth. The mind was not peripheral to healing. It was central. Pain was not just tissue damage. It was story. It was context. It was trust. And in the crucible of war, trust, delivered in a syringe of salt water, had saved lives. Beecher closed his locker. The war was over, but the work had just begun.